This year and in the last 5 years, I think we can state that we are really facing a new era for the CMV infection and the reactivation and disease for allogeneic transplant recipient. And I think that this can be mainly related to some innovative drugs we have in our hand now, for example, regarding the prophylaxis with Letermovir, but also new drugs that are coming for the preemptive treatment and therapeutic strategies for resistant cases like maribavir, for example. So we're really facing a new era for that. And also in that context, I think it is important, as I have also presented during the EBMT meeting this year in the Cell Therapy Day, that contribute that also the immune monitoring for specific CMV T-cells after the transplant can give. Because, for example, we have seen in my presentation that post-transplant cyclophosphamide as GVHD prophylaxis not only post-identical transplant, but also with all the other sources, it's related to a higher rate of viral infection, mainly CMV. In that context, the prophylaxis with Letermovir is undoubtedly able to reduce in the first 3 months after transplantation during the prophylaxis the rate of CMV infection and disease. But we have seen also that this seems to postpone after these 3 months the risk of CMV in our patient. So we have to consider that now we can have also risk for CMV after the first 3 months after the transplant in our patient. In that context, it is important to underline that CMV-specific T-cell immunity may really improve our clinical management, and I am really expecting for the future to have really more use in our clinical practice. It can help also to improve the risk of stratification for our patient and to identify patients that measure risk for CMV disease and also for subsequent CMV reactivation, and also can be really an important additional tool for managing transplant recipient at risk for this CMV reactivation. For example, specific CMV immunity measured after the transplant can help us to guide the duration and intensity of CMV viremia monitoring, so the surveillance of the virus after the transplant, because now we have some guidelines also giving more surveillance in the first 3 months after the transplant, but we can adapt with also the information regarding immunoreconstitution when stopping the prophylaxis, in what cases we need to monitor carefully also after the first 3 months. For example, the CMV immunity is able also to adapt the duration of CMV-specific prophylaxis, because at some stage 3 months is not sufficient to completely cover our patient from the risk of reactivation, because Letermovir seems to delay also the immunoreconstitution of our patient from the first data we have. And also the CMV immunity measured after the transplant can really help us also in the management of the preemptive treatment, in the starting, in the decision in which time point to stop, and also the duration. However, I think that, as I mentioned during the EBMT Cell Therapy Day, it is important that we also underline for the future the open issue that now we have, and it's the type of assay we should use for measure the CMV-specific immunity after the transplant, which are the best time points after the transplantation that we should use. And also we really need harmonization and standardization of our immuno-monitoring protocols after transplant among EBMT centers.